Hello, everyone, and welcome to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein. And as always, it's my pleasure to welcome Dr. David Reznik with us. Now, we're going to do something a little different today. When you registered, we actually asked if you had any questions. So this is going to be a live Q&A session. We've taken down and categorized most of the questions you've asked, but we're also going to take some time during this program. If you want to type any questions in the Q&A or if something comes to mind, please do, and we'll try to get to as many questions as we can. With that, I'll turn it over to Dr. David Reznik. Dr. Reznik, great to see you again.
It's good seeing you too, Dr. Severance. Always a pleasure. I want to take this opportunity for thanking all that have joined and all that have submitted questions, as well as thanking Henry Schein for sponsoring these talks and OSAP, the home of the safest dental visit and infection control for dentistry. Okay, there we go. I do want to say that the opinions that you're going to hear today, or the information that you're going to hear today, is coming from research that I have done and questions that I have talk to with my infectious disease colleagues that I work with on a regular basis. This is not something that is truly from Henry Schein. So that's our disclaimer as we move forward. So the first area of questions that came up, not surprisingly, from people who watch these webinars almost for 11 months now, is about personal protective equipment and PPE. So what PPE is considered mandatory in the dental setting? I don't think there's been any real changes to what we've gone over in the past. The CDC guidelines are still the same. My staff is wearing fit-tested N95s. They have a covering over that. They wear face shields. If they're involved in aerosol generating procedures, they use disposable gowns. My staff, those with and those without hair, are wearing hair guards. We never went to the hoodies. We did rule that out. But as far, and of course, gloves. Gloves is very important. So we have a new normal, I think. And our new normal is just like it was back when HIV first hit, when some of us who were old enough actually did what's called wet finger dentistry. We did not wear gloves, which the thought of is somewhat horrifying to me today. We really have never worried about aerosol containing pathogens before in the dental setting. Probably wasn't the smartest move on our part, but we are catching up and taking the lead. If you really look at dentistry and the steps that we have made towards infection control and how we've adjusted to this new pandemic, I'm very proud to be a member of the dental profession. Should there be any changes to the PPE requirements once you're fully vaccinated? And again, the answer really is no. We want to make sure that you stay protected. None of the vaccines are 100% foolproof. That's number one. The vaccines that are presently available in the United States are 94 and 95% effective against the original strain. It does look like there might be some good results that we're starting to hear about our T-cell response. We know that the antibodies might not be as good against certain strains that are out there, though we have a humoral response that comes out later. So we still need to wear all of our PPE. We still need to take all of our special precautions that we've been taking, even if you've been fully vaccinated. Remember, not everybody at this point has been fully vaccinated. We are vaccinating our healthcare workers. And in most communities, people that are 65 or older. In some communities, that is 75 or older. So really, please don't change your PPE once you're fully vaccinated. We don't even know at this point, if you are fully vaccinated, is it possible that you could still transmit? So this is still new. This disease has been around a little bit over a year, and we've made remarkable progress. Today, the NIH released that they're going into phase 2 and 3 studies on 4 different kinds of treatment. So from where we were back in February and March and April of last year to where we are today, the changes have been remarkable, but we can't afford to let our guard down. And that is really, truly important. So what do you think the determining factor, if any, that will allow us to relax these PPE precautions a little? Honestly, I think that we're going to have to learn to wear when we're doing aerosol generating procedures, I think the determining factor is going to be actually some new dental control. Will we be able to do aerosol generating procedures, but not produce as much aerosol? Face shields, I have worn face shields since they became available to my knowledge. I will always wear some kind of eye protection. As I mentioned previously, it's something I learned from Kathy Eklund a long time ago, that my glasses are not eye protection, that I need to have some kind of goggles. So will that change? No. Will wearing a fit-tested N95 change as long as we have a relatively new pathogen out there? I really don't think so. So I do think there can be some changes as far as treatments, as far as vaccination, that might make this more of a continued process. But I think right now I'm just not ready to say we need to let our PPE precautions go down. And as far as mandating dental settings, I think if you're doing a mandatory PPE, if you're just doing something like a simple exam, then a lab coat is fine. And the CDC website and dental infection control actually has a wonderful example of when you're doing aerosol generating procedures as opposed to when you're not doing aerosol generating procedures, what it should look like. So hopefully those answer those first questions as far as PPE is concerned. The next questions that we have go to what do we think about masks? What were some of the questions that came about face masks or respirators? Should we be double masking in public versus in the dental setting? So I'm going to answer this public question first. As you know, Dr. Fauci was on television and he said, well, 2 would work better than 1. And then he sort of backtracked a little bit and said, we really didn't have much research. Well, now, as of the last year or 2, CDC has published research. And we do know that either a really well fitting mask and a double cover over it are important. And so how do we do that really well fitting mask? And I'm actually looking for a prop. But what we need to do is tie a knot near the mask, near the face mask, and tie a knot on the other side and then put it over your ears and then tuck. So it's really knot and tuck. You want those level 1 or 2 masks, face masks, to fit tightly. So that's your number 1 thing that you can do. And then when you're outside, if you want to put on a cloth covering over that, that's fine. So you have a fit testing medical mask, not a fit test, a well-fitting medical mask, and you have a covering over that. And now we do know, based on research that was done at the CDC, that 2 is better than 1. Should the surgical mask be over or under the KN95 or N95? So let's go to where the whole concept of an N95. The N95s should be fit tested for the dental practice. If you have a new brand of N95s that come in, you need to be fit tested initially for that new N95. So the N95 is a very tight fit. So the N95 would go close to the face and any other kind of mask would go over that. The whole object is to protect the mask from getting wet. In dentistry, with all of the wonderful things we have, most notably our fabulous dental assistants, we have also high volume evacuation, we have extraoral aerosol containers, we're wearing containment objects, we have air filtration devices now, we have all this new technology that we're using, including just the old-fashioned face shield. It's very difficult to get the N95 wet, but it's really important to remember, don't get that wet, whether it's on the inside or the outside. Is there a way double masking can be more effective or defective? Yes, if you're using very porous, homemade, not really good masks, it's not a good thing. If you put on a mask and you did the old-fashioned way of just trying to cross it over your ears and it doesn't fit well, then you're not doing yourself any service. The whole goal is to have it nicely fitted against your mouth. So and your nose. Too many times when I'm in public, I see chin masks, or I see people walking around and their nose is out. And then I always get, well, my nose isn't as big as yours, Dr. Reznik kind of comments. But the whole object here is to have a nice, tight fitting mask that covers your face prevent you from giving something to someone and for you from getting something from someone. Another question came in talking about, we have N95s and a written respiratory protocol. Those are actually fabulous things. I could just say that at this point of this question. We have been told the N95 needs to be fit tested, I think is what they're trying to say, for every person. Is that true? And yes, it is. Every new member of your staff or every member of your staff should be fit tested for an N95. And that involves just having the mask put on and then different kinds of a sweet smell and acidic smell, different kinds of smells that you go through to see if you can or you can't smell it. If you can't smell it, then you don't have a tight fit. So the whole object is that every staff member that is involved in clinical care should have a fit tested N95 on. What has been waived during this emergency time is annual fit testing. I don't know how long that's going to stay a problem, or actually I should say how long that mandate will be relaxed. But right now, every new N95, and that means brand. So for instance, I have this brand of N95 right now. I'm not really trying to sell it. Have I been fit tested for what I call the Donald Duck version? And the answer is yes. At one point, the people upstairs were using this kind of N95. Were they fit tested for it? And the answer is yes. And so basically going through whenever, before I was using the 3M N95s, and that's what I had been fit tested for. When the newer N95s came in, I, like everyone else, had to be fit tested for this to be following OSHA's guidelines. How can we know for sure if N95s are FDA approved? Another great question, because you can go online and you're not dealing with a wonderful company that you know is going to buy the best product, but you're trying to find some maybe on Amazon or however people look. And you can go to the CDC's website. They actually have a list of the FDA approved N95s. You can go to the FDA's website and look for the emergency use authorization for KN95s. There are probably other sources, but right now I would say the best source to make sure that your N95 is FDA approved would either be the CDC site or look at the FDA site. The CDC site is quite comprehensive. If we are fully vaccinated, can we now wear level 3 masks when seeing patients? Again, the vaccines, although they are wonderful, and I've had both doses now, I do work in a hospital setting. No vaccine at this point is 100% effective. I don't want to tell somebody, don't wear a mask that's going to keep the aerosol out, because a level 3 is really good about keeping fluid away from you, but it really isn't very good about keeping the aerosols away from you. So if you are fully vaccinated, the guidelines, as I'm aware of them at this point, is you should still continue to wear your N95. So now we're going to take a little break. Let me have a little sip of tea here and see if any questions came in.
Make sure it's tea and not what Tom Brady drank, the other kind of tea. Okay.
No avocado tequila.
Question for you. Any new protocols on reusing the N95s? Remember way back when we had those questions because they're a short supply?
And that's actually a great question, so thank you. Actually, the CDC has changed that recommendation on the number of times that an N95 can be reused. I do believe, and I'm sure there are people on this call today who might know a little bit better than me, but it's down to 4 or 5 times that you can reuse an N95, and that's about it, as opposed to, I think it was 20 or 30 times you could reprocess one. So they have limited the time, the amount of time that you can actually reuse an N95 because it loses its effectiveness, and we don't want to put anyone at risk. Great question, and thank you.
Yeah, and we have some other questions that will be coming later in the program based upon the subjects, but another mask question. And maybe it goes back a little bit. First, one of the people asked medically fitted. You then mentioned fit test, but there is also a medical release, correct, that they have to have signed in order to be able to wear the N95s? Part of the question.
I'm not aware of a medical release that you would need unless you are asthmatic or have difficulty breathing. And I
Yeah,
think that that's something that we really need to take into consideration. Some people are going to overdo the number of masks they put on. Make sure if you double mask, you can breathe. That was one of the biggest concerns. I have a couple on my staff that are asthmatic, and I was very concerned about their ability to breathe. And I can honestly say, without promoting it, that duckbill mask does make it easier to breathe that I was showing.
Great.
So
One more
thank you.
mask question. Do you need an initial fit test for a KN95? And maybe you want to explain the KN95 since we haven't mentioned it too often.
So, okay, that'd be great, Gary. A KN95 is actually Chinese manufactured N95. It is as effective to their standards as reducing 90% of the particles, 95% of the particles that come in. However, I am unaware of any recommendation to have those fit tested, just the N95s that are approved through NIOSH, the NIOSH approved N95s that the CDC and FDA website will have. I do wear, however, a KN95 when I'm out and about. I will be frankly honest, I feel like I have the best protection. And then I put my favorite football team world championship mask over that.
And then we've got a very knowledgeable audience, as you know, over the year of presenting these. One of them came back and said, you do need a medical clearance. That can be a call to your physician or others to make sure you have the breathing capabilities with the mask.
Right. But as a general, in a hospital setting as large as the one that I'm in, we do not require a medical check for all 6,000 or so employees in the health system. It's those who are asthmatic that you would want to have checked.
Okay, great. Okay. Let's go on.
Thank you for those questions. Keep them coming. So far, I'm okay. Here we go with the next set of questions that were in there, which has to do with patient screening. What screening questions should we be asking our patients? Again, those questions haven't changed. Do you have a persistent cough? Are you running a fever? If someone is running a fever that is not odontogenically related, they should not be coming to your office. Do you have a loss of taste and smell? Are you having shortness of breath? Do you have a new round of diarrhea that maybe that's not something that's normal for you? So those are the kinds of questions that we're doing. We are still screening our patients for temperature on a daily basis. I will say that our hospital has stopped screening our staff. They realize, and hopefully if you work in a hospital or you work in a dental office and you're running a fever, that you stay home. That's really important. So also there are travel questions that some people do ask, but you know, a lot of that travel is being curtailed, at least international travel is being curtailed. But it's really, so were you at a Super Bowl party with 150 people in a small group? I mean, if you want to ask those kinds of questions, that's fine. But literally, we're asking medical type questions. What should preclude patients from coming to your office? They haven't been vaccinated and they've been around someone who tested positive for COVID. I think that would be a good answer. They're running a fever that's not related to the oral cavity, so they could have flu-like symptoms. They should not be coming to your office. If they're caring for someone who has COVID and they haven't been in through that quarantine period because they haven't been vaccinated, they probably shouldn't come to your office. So those are just some general, simple answers to some of those points. If point of care testing is available on site, is it recommended to use this to pre-screen patients? And this is a really, truly interesting question because I had a wonderful call from a dentist recently who said that had a patient who had previously tested for SARS-CoV-2, and when they came into the office, they were doing antigen testing and they remained positive. Could we see that patient? Well, it's very probable that even after the person is infectious, so after that 2-week period or 10-day period of time, that they'll have viral particles, except they're not infectious. So that point of care testing to screen out patients can give you a lot of what we would almost assume to be as false positives. In other words, someone had SARS a month ago, had COVID-19 a month ago, and then they come in for a dental appointment and you're testing for them and you get a positive antigen, does that mean they're infectious? And right now the answer is no. If they think they might have been infected recently and they're not symptomatic and they want to test, that would be a different way of screening, but not necessarily to screen out someone for getting dental care, but to screen them that maybe you need to call up your physician because you've had some differences, you've lost your sense of taste, it's not related to your oral cavity, and you were concerned, so you were able to get screened in the dental setting, and they said, well, this did come back positive, maybe time to call the doc. And I think our medical colleague, I think that's a better response to that. So I really wanted to do screening in here. That was one of my goals, was to screen our patients as they came in so we could literally find out if they were positive, not because we wouldn't see them, because we're using all of those new infection control guidelines. So we are putting on all the appropriate PPE. We do have all that new technology in the program. I honestly think the air is much cleaner in my dental office than it is in my home. So I think that those are some questions that will change as time goes on, but again, great questions. As far as quarantining, that is changing, especially for people who have been vaccinated. If the staff has fully been vaccinated and wears appropriate PPE, and I have to move the picture down, do quarantine rules apply if exposed to a patient with COVID-19? Fabulous question. And the answer is actually no. If everybody in the staff has been fully vaccinated and you're wearing appropriate PPE, no one needs to be quarantined if exposed to someone COVID-19. So that's one of the most important points I want to make today. Once a person is vaccinated, and it's been several weeks since receiving the second dose, are there any changes to quarantine requirements? And the answer is yes. You don't need to quarantine if you've been exposed. So that doesn't mean that you still don't wear your PPE when you're out, your mask when you're out, and you take all your precautions when you're out. Yes, but you do not need to quarantine. These are the latest guidelines. And so I think the third question is basically a repeat of the first two questions, but I see something popping up in the chat. So let's see where we're at. I think there's time for live questions, Gary.
Yes, lots of good questions, and we'll take these breaks and you can continue to ask them. Back to the screening a bit, should or can a patient screening include, have you been vaccinated and when?
I think that's not a bad question. Remember, all questions are good, so I don't mean to put anyone off. All questions are great questions. As long as you are wearing your full PPE, as long as your office is doing everything that they can to provide the safest dental visit, then proof of vaccination doesn't really mean anything. If you're wearing N95s and a face shield and you have on eye protection and gloves and a disposable gown and head materials, does it matter that someone's been vaccinated or not? Am I going to not want to treat somebody who is 60 that hasn't been vaccinated because they're not old enough, or they're in Massachusetts and they're 67 and the age right now is 75? I mean, these answers will change as we go along, as more vaccine becomes available. But right now, there's no issue though. I don't think that's the best question to ask. It's a good question. I think you could document in the chart, patient has been vaccinated for. I think that's a great thing to document. I think it's a new addition to your medical history. That would be great.
Great, and then some interesting ones here, more specific, but in general, and I think you just covered it, but the question is, are you recommending that dental offices not treat patients that have not been vaccinated?
That was a double negative. So do I think we should treat people that are not vaccinated?
Yeah.
Definitely. My patient population that we treat now, and we're up to full service. We're doing all aerosolized generating procedures. We have taken all kinds of precautions here. Most of my patients have not been vaccinated. So I'm treating people, I think the simplest way to put it is, since HIV, we treat every patient as if they have a bloodborne pathogen, although most do not. In this case, we have to treat every patient as if they have COVID-19, although most do not. And so we need to keep those precautions in place for the foreseeable future.
Great. Then some specifics on individual cases. This person has an employee whose husband has COVID. He or she has been tested negatively, but obviously she could be infected at any time since she is still living with him. What's the procedure, or how soon should she come back to work?
Well, that's, if she has not been vaccinated, then you would follow the normal quarantine rules. So it would be at most 14 days would be the case. But I have a staff member whose significant other, her boyfriend, tested positive. She came to work. I mean, she actually put him in the basement and stayed away from him and took all the safety precautions that were necessary. And as long as they're following necessary precautions, and while they're in the dental office following normal PPE, just follow the medical advice from the primary care physician.
Okay, and kind of a follow-up to that, this person has someone in the office that's living with two people with COVID positive. How should they be treated coming back into the office?
It depends on how long those two people, how long ago did they test COVID positive? Were they asymptomatic and never had much of an infection? If they ran a fever and then it's been 24 hours past that fever. So again, these questions are great questions, but they're multifactorial. Someone, like I just mentioned, could have had COVID 2 months ago and have an antigen test and test positive. So does that mean they can't work? No, it means they're not infectious, but they have non-infectious viral particles. So I really think when you look about just releasing people from the hospital, it's about 7 days if it's a person who is not severely immunocompromised. And then for people who are severely immunocompromised, after an average of 15 days, they no longer have infectious particles. So the object is, if it's healthy individuals, probably 7 days is enough. But again, check with the local people.
Great. And again, we have some questions that'll come later that are up here, so we'll still try to get to them. One of the questions that I think in this category from Helene, are most states still having capacity limits as to how many patients can be in the clinic at a given time?
That would be a state-by-state decision. There is no limit to the number of patients that we can have in the clinic in Georgia. And so what I do, though, is my waiting room, which used to hold closer to 15, now holds about 4. The hallway, which didn't used to hold any patients, holds about 3. And we do a really good job of scheduling. And we follow a lot of those ADA guidelines on, texting a patient if they're in the car. We try not to have them wait in the facility too long. We screen patients on the way into the building. We give people, if you're having X, Y, and Z symptoms, we call ahead of time. So we do all of those things, but I'm not aware, at least in my part of the country, of any limits on the number of patients that you can have in a facility at any given time.
As long as the spacing is taken.
As long as you're doing the spacing right. You want to make sure, because we have, unless you're putting your filtration devices in the waiting room, which in my new clinic I will have in my waiting room, so we'll have a great ventilation system and good ventilation. We're still going to follow that physical distancing of being 6 feet apart. I'm not risking the safety of those I've served all these years or my staff for any reason. Got to stay safe.
Great. All right, let's continue on.
Thank you, Gary. Air management. Here's a question about ultraviolet light in the upper room air. Is it a standard of care? I don't know that we have actually developed a real true standard of care on how people are going to address this. For instance, my ultraviolet light, and I do have them, is actually a part of my extraoral chair-side evacuator. I actually use the Vaccinations. So that way, when it comes to air management, we'll get it at the point of where the splatter and aerosol is coming from in a relatively large cup. It's then going to go through multiple filters, and the last thing it hits is UVC. So UVC is important. It can be something that you can put into your HVAC system if you do it appropriately. But again, I am much more of a bigger fan of trying to address the source of the splatter and the aerosol, because we know that high volume evacuation is going to get about 90% of splatter and aerosol. What happens to the other 10? I want that other 10% to actually go into a device and not wait until it's in the air and not waiting until UVC gets the opportunity to kill it. Remember, UVC has to be in direct sight of the pathogen. Are air filters efficient in reducing contaminated aerosols? I have heard conflicting information. It really depends on which device. Of course, HEPA filtration is going to reduce contaminated aerosol. But again, the devices that I'm using have more than one type of means of filtrating the air. So I'm using technology from Radic 8 called virus killers, which actually filter the air and again, kill the pathogens that are inside. So I think air filtration is a remarkably important component. We're trying to address the air in our office. We're dealing with a pathogen that can be easily transmitted from one person to the other. And when we think about the variants, the concern with the variants is they're twice as contagious as the the initial strain is. And so we literally have to use a combination of things. So I would never say air filtration is a bad thing. It's just important that you do change your filters on a scheduled basis. And some with multiple filters, you're going to have to really figure out how to get that onto part of your infection control standards. Is using high volume evacuation, something like the release system, along with extra oral suction devices, like I just talked about, effective in protecting dental hygienists if they don't have a hygiene assistant to work with and suction? Extraordinarily good question. I have a staff of 3 dental hygienists, and what we have is high volume evacuation. We have a system in place, a relief type system, and each of my dental hygienists has an extra oral evacuation device. And since the beginning of this epidemic, when I allowed them to do aerosol generating procedures, when all of our equipment was in place, there has been no transmission in my office. My staff has remained safe. So I'm a big believer in having that type of relief system along with the extra oral suction device. I don't think the release system alone is good enough because it'll change the direction of where the aerosol and the splatter is going to go. It's not going to be able to catch 100%, but with a really good extra oral suction device on top of the release system, yes, I believe it is safe. And that's just because there's only so much repetitive motion that an individual can do before their hands start to break down. And so we have these high volume evacuation systems, and we have these extra oral evacuation devices for patient protection, for provider protection. And we also want to make a use of the equipment that we have, such as ultrasonic scalers. So I know that it's recommended to avoid them whenever possible. It's not always possible. So therefore, I believe that that's fine. And again, this is my opinion.
Dr. Reznik, can we just stop on this point because we have several associated with this slide.
Sure.
Is there and you've answered it, but maybe you can reiterate, is there a change in the status of using ultrasonic scalers?
I don't believe that the American Dental Association has actually changed of their recommendations. I think that's on a practice by practice level. And in my case, since I have When it comes to infection control, when it comes to the safety of my patients and comes to the safety of my staff and my residents, my number one priority is that. It's protecting their safety. So I don't know if there have been changes as far as organized dentistry is concerned, but as far as I'm concerned, if you have the proper devices in place and you have skilled technicians, then it's fine.
Great. Okay. And then a follow-up on that too is on this air management. And we thought this would come up. What are your thoughts on fogging with hypochlorous acid?
I am not opposed to any technique that anyone uses to create a clean environment. I will say that one of the changes, even though hand washing, one of the most important things we do is hand washing, wearing a nicely fitted mask and physical distancing, all of those things are still in place. The one thing that has changed since I first started doing this is we really don't believe that fomites, things that land on surfaces, are a way of contracting the disease. In other words, it's airborne from someone's cough or whatever, or for an aerosol generating procedure if you didn't have any kind of protection on. But as far as touching surfaces, does that mean we don't wipe down everything? No, we wipe everything down after every patient. If you want to fog, that is perfectly fine. You're going above and beyond, and I think that's fine. But just about viral particles living on surfaces, we made a big deal about that early on, like stainless steel, I believe was 4 days, something of that sort. It's not contagious. We don't think that that's the way that people are getting this disease at this point. That's CDC information, and a fabulous question. Thank you, Gary.
Yeah, and one more on UVC. One of the questions was the upper level, and you made it a point to say, you have to be a certain distance, it has to have a dwell time there, and it has to have the power of the UV light. So now people are looking at UV light wands to either do their masks or counters or others. Have you had any experience or thoughts on that?
There are different ways of disinfecting the masks. We were doing that for a while we had a trial of honestly, it looked like a toaster oven, Dr. Severance. And we would put our iPhones in there and masks in there, and it would be in there for a certain period of time, and it would be fine. Again, I am not opposed to any step that you take that is going to make your environment safe. So if you want to use UV wands and you're following the manufacturer's instruction for use, that's always the most important thing. Don't just wave it over, follow those instructions. And then when it comes to solid surfaces, I'm a big believer in wipes. I've never been a believer in sprays because I years and years ago had an issue with the spray. So I love the wipes that we have there, and they keep the surface time wet long enough. And we're only talking about for certain types a couple minutes. So I'm a big fan of that. You want to have UV wands, any extra infection control steps you take for the safety of you, your team, and your practice is fine.
Great. And then one that's very dear to Henry Schein specifically because of the charitable events that we do, Mission of Mercy, Give Kids a Smile, some of these big smile programs that help serve the underserved in many cases. How do you think, and they may do them in a big stadium, a big convention center, how do you think they're going to look in the future?
That is really a great question, and one I'm really not prepared for. But honestly, I think that it's going to take programs such as myself and teams of people. And I know I've worked with some of these wonderful people at Missions of Mercy, and they bring in remarkable equipment and have remarkable infection control practices. But we're going to have a little bit of a different environment. With this involved, instead of having a whole room full of people with no kind of divider, that we have some kind of plastic dividers between operatories. Will we try to get everybody who's willing to lend an extra oral evacuation system into a football stadium or a convention center? I would find a way to get my materials down there to help those in need. That's the kind of service we've been doing at my health system for 120 some odd years, and I would be more than happy to participate. So their ways, they'll be different, that we have fabulous people who run this. I've met them at OSAP conferences. We have wonderful, gentle teams around this country that really go above and beyond, and we might have to go a little bit further now, that's all.
Right.
But
All
they
right,
need
let's
to
get on.
exist.
Yeah, let's go on to
The next one, ready for me? Okay. So vaccinations, the hot topic. Can the COVID vaccine give me COVID-19? A very common question that comes in. None of the vaccines that are available, so the two that are available in the United States, the Pfizer BioNTech, as well as the Moderna, contain live vaccine. So live virus. There is nothing in there that's live. It has a messenger RNA that sort of tells the spike protein what it can't accept to. So you cannot get COVID-19 vaccine from the existing vaccines that we have under emergency use authorization in the United States, and even the ones that we're considering, such as AstraZeneca and J&J, they do not contain live virus. You cannot get COVID-19 from the vaccine, the same way you cannot get the flu from the flu shot. One of the best possible things is really not good about this whole period of time, but if you've noticed, there's been very minimal flu this year. And that has a lot to do with the precautions that the most of us are taking in our normal daily lives. What are some of the possible side effects of the vaccine? Do they differ? Do they differ based on which vaccine you receive? So there are many different side effects that you can have. The one that I've heard most is injection site soreness. When I had my first dose of Pfizer BioNTech's vaccine, I didn't even notice it. When I had the second dose in the middle of the night, I apparently rolled over onto my left shoulder because it woke me up on my left arm where I got the vaccination. As long as I avoided it, I was fine. People complain of flu-like symptoms, of muscle aches, of being tired. Those are really common types of things that you hear in the next 24 hours. I had my vaccination on a Friday. I'm normally tired on Saturday, and I'm normally sore on Saturday. I put together 2 webinars that Saturday because I wasn't missing the NFC Championship game. So the vaccine side effects, what you really need to be aware of, if you have a history of really bad allergies, of having an anaphylactic reaction to something, then that's where you have some concern. And there are about 11 cases per million doses of that. So that is not very likely to happen. And that's why when most people get vaccine, we watch them for 15 minutes. Again, is there different? You know, you hear things on the street that Moderna might have more of a little kick to it. I really haven't witnessed that or seen that. I've had people at different ages. It's really sort of funny. Some of the younger people have had more significant muscle aches, felt like they ran a small fever, but it's gone within 24 hours. Will COVID-19 vaccines become mandated anytime soon? Well, the federal government cannot at this point because they're under emergency use authorization. And as long as they're under emergency use authorization, the federal government cannot mandate that you become vaccinated. So and if you look at a recent poll from the Kaiser Family Foundation, you will see when you look at vaccine hesitancy, how it's split basically just amongst general people. The number of Caucasians who are hesitant, around 51%. Number of African Americans, I think, was somewhere around 15%, and Latinx around 19%. If you looked by political affiliation, it was split. If you look by parts of the country, it was split. So I don't know about mandating. As far as work places, now that can be dictated by state and local authorities, and that's something you should check into. As far as it being mandated in my state, no. Well, do I think it'll be mandated anytime soon? I don't know. I don't believe so. But in my hospital, we do mandate that you get the flu vaccine, and you have to have a medical reason not to get the flu vaccine. So there are certain mandates that certain health facilities and employers can put into place, and that would follow under state law. So you really need to check your state. Which vaccine should I get? Do I have an option? I don't know that you have an option. I didn't have an option. When my turn came up, I was willing to get either one of the 2 mRNA vaccines that were available. They're both about 94, 95% effective. So I don't know that many people have an option at this point. There's just not enough vaccine. I think we saw that this week when California and some places were shutting down vaccine sites, and how difficult it is in some localities, including friends of mine in my own state, who are having a hard time getting vaccinated, and friends of mine who live in different states. So I don't know that we're going to have a choice anytime soon. Do we have a choice of flu vaccine as an example? No, we just take the vaccine. Do we have a choice of shingles vaccine? Well, I don't think we really truly have a choice there. The next question, actually, Pfizer and BioNTech is actually the same vaccine. I think the question really means, if you had Pfizer BioNTech as the first dose, could you get Moderna as the second dose? And according to what's come out of the NIH and CDC, that is only allowed under very unusual circumstances. They truly want you to stay within the type of vaccine you get on dose 1 and have the same kind of vaccine on dose 2. So that's where we are at present time. Can I get the vaccine if I've already had COVID-19? You sure can. We don't really know how well the antibodies are that you formed when you had your case of COVID-19. Did you have an asymptomatic case and just tested positive? Maybe you had a weaker antibody response. Even if you had severe disease and you formed a great deal of antibodies, we don't know how long those antibodies last and are effective. And we're just beginning to look at the other side of the coin. How does our T cell system really function? And we're beginning to get some data on that, showing that once the antibodies sort of die down, the T cell system will help and will kick in. So yes, if you've had COVID-19, please get vaccinated. Try to stick with the same vaccine. I don't know very many places in the country that are giving one or the other. I mean, let me reword that. We've had both vaccines at our hospital. But if you got Moderna on dose 1, you're getting Moderna on dose 2. If you got Pfizer BioNTech on dose 1, you're getting Pfizer BioNTech on dose 2. Now, we will have some new single dose vaccines that will be under emergency use authorization in the near future. And then that might give you a choice. But again, they may not be as effective, or they are as effective. We just have to see what the data shows when the EUA comes out. With no long-term studies, how do I know that any of the vaccines are safe long-term? Great question, because this is a new, virus. However, these vaccines do not enter your cells. They just basically cause a change to a pathogen that's out there and its ability to cause disease. So they studied them now for a good deal of time, and I would not put myself or a family member at risk. I think you're more at risk for not getting the vaccine than getting it. And I'm sorry, I'm trying to move my little picture box here so I can see the question. And that didn't do that. Can vaccines cause permanent health issues in someone that is healthy? To my knowledge, unless they have had a history of anaphylaxis and then that can be dealt with immediately, there are no reports, there are no studies out that I'm aware of, or case reports about vaccines causing permanent health issue at this point. Is there further data on safety for vaccines for pregnant women, or I imagine women looking towards pregnancy? And there is not a great deal of safety information out there, because we normally try not to do studies on pregnant women. but there were a lot of women who had been in the trials who actually did get pregnant after the vaccination. And so according to the ACOG, the American College of Obstetricians and Gynecologists, and yes, I did have to look that up, anybody who is wanting to get pregnant or who is pregnant or who is lactating can be safely vaccinated. So those are some important points because dentistry, I think, is turning into a woman-dominated field. We have more female dentists entering the profession now than men, which is a fabulous thing to hear. I'm all about equality and equity whenever possible. So yes, if you're planning on getting pregnant, you are pregnant, always speak with your OBGYN. Don't listen to your dentist. Always speak to your OBGYN. But from the data that's been put out by the CDC, it is recommended at this point. I received both vaccines. Now what? How will it change my life in practice? Well, when we have more people who have had vaccines, when we have more of the United States that is vaccinated, right now, I think it's less than 10% or so of this country has been vaccinated. And it really also depends on where you live. So if you're out in a very rural area and you aren't around people and you're in open airs, it's not going to change your life. But as long as we're performing dentistry and we're in relatively tight-fitting facilities that might not have the best air exchange, I don't know that it's going to change your life except to give you peace of mind that you are not going to become sick from COVID and that you would not hopefully transmit this disease to any of your patients. So it should give you a sense of better well-being, more confidence in what you're doing, more confidence that you can safely practice the professions that we all have spent our journeys performing. After receiving the second dose, can a person still be infectious to others? This is such a good question that we really don't have an answer yet. I hate to use the word assume, but that's the first word that came to mind. There is a small percentage of a chance that you could be infectious. And so we really just want to make sure that you continue to take all the precautions, which is why your life and your practice hasn't really changed other than a sense of confidence that you will not get sick. But we want to make sure that no one else gets sick. And we don't know about asymptomatic spread and things of that sort. So after receiving your second dose, still mask up in tight spaces, still protect others. Always make sure that you're taking consideration yourself and those you serve and your friends and family. If your staff are hesitant towards taking the vaccine, would you try to convince them to take it? And if so, how do you approach it? One of my favorite questions. Earlier on, before the vaccines were available, I gave a little sticky pad, piece of paper to everyone on my staff, to my assistants, the hygienists, the dentists, the residents. And I said, I didn't ask it three ways. Would you get it now? Do you want to wait to see what happened, or you won't get it? I just asked yes or no. And so it literally ended up that I was shocked. 67% at that point, that was before they were emergency use authorized, 67% said no. 33% said yes. So I knew I had work to do. So what I did was just what I'm doing today. I spent some time, not every day, but educating my staff, giving them information that would make them feel more comfortable about it, setting an example. Those that were hesitant at the beginning, after they saw almost 80% go and get the vaccine, so the effort worked, then their hesitancy stopped and they went and got the vaccine. I have one staff member or two staff members that I'm aware of that haven't gotten the vaccine. One has a history of severe allergic reactions, and therefore it's understandable, and that individual's front desk, and one other staff member. So my approach was, I didn't mandate it, I wasn't forceful about it, I tried to educate on it. I tried to talk to it. And then I had people on my staff, because sometimes they get tired of hearing my voice, for obvious reasons, I would get other people on my staff to talk about their experience with the vaccines. What happened on day one? What happened after their second dose? What if members of my staff don't want to get the vaccine? Make sure that they are constantly masked while in the office. They have good mask on, face mask on that fits. When working with patients, they have on their N95 and all their protective equipment. Make sure that they follow all of the existing rules, unless you have a practice or you're in a state where you can mandate that, having them do every step they can to protect themselves. We don't want to turn this to an us versus them or you didn't get vaccinated kind of thing. We really want to get people to realize we're trying to create a safer world for all of us, so we can eventually get back to some semblance of normalcy. So we can go to a Super Bowl, we can go to Super Bowl parties, we can go out to dinner on Valentine's Day and the places not be just 25% full. So I think that it's education is how we get rid of fear. Education is how we get rid of mistrust. And there is mistrust in certain communities that we really need to make special efforts. I think Grady Health System did a wonderful job by getting a very famous person to do a presentation on vaccines and why it was safe. And of course, the person's name just completely escaped me. Can I make it mandatory for my staff to get the vaccine? That depends on your state and your state laws and your state rules. I don't believe I could make it mandatory in Georgia at this point, especially something that's under emergency use authorization. I definitely would not mandate that my patients get vaccinated. I mean, if we did that now, we'd only be having geriatric practices or healthcare practices. Who would we be treating? They would have to be 65 or older in certain communities where they've actually been able to get the vaccine. So you're talking about dental industry is coming back, but if you mandate that everybody has to be vaccinated before they come in, then your practice is probably going to sustain quite a hit. That's why we have this wonderful guidelines on personal protective equipment. That's why companies have developed remarkable technology that addresses air quality in dental offices. That's why we're creating new things, including in some extreme cases, negative pressure rooms, like I have a negative pressure room because I'm blessed. So hopefully those questions are helpful. And then the next session's on dentists administering vaccines. Gary, do we have any questions about getting vaccines, or should I just move forward?
I probably will let everybody know we will be going over the hour. We've got lots of questions and I'm sorting them out when possible. So there are some, but we can continue with this slide and then I'll group them all together on vaccines.
All right, thanks, Gary. I lost track of time. I'm a chatty person. What is to be gained by dentistry admitting COVID vaccines from our practices? One of the biggest challenges that we have right now is getting people vaccinated. So I know that we have emergency authorization in Georgia. What I was not looking to do was to vaccinate people who come into the program. I work in a comprehensive healthcare setting, but if the hospital needed someone, because nursing is at a premium, if they needed someone to help administer the vaccines, I would go over there and I would give vaccine. That's why I took the training courses. There's a few training courses available on the CDC. I also think it's part of what we've always been. We are part of primary healthcare, and we are part of a very important effort to improve the health of the country. Will dentists help with giving vaccines in private practice? I really do think that depends on which state that you live in. In Georgia, that would not be the case, but in some states, that may be the case. Here we are for the live questions, Gary.
Great, thank you. Yeah, we have a question regarding vaccinated dental employees and travel. If they travel, do they still have to quarantine prior to returning to work?
If they're vaccinated, fully vaccinated, and they've had their 2-week period of time, they do not need to quarantine when coming back.
Okay, And then we have read that after 3 months of vaccination, the quarantine rules apply if exposed to someone with COVID-19. Is this the case and why?
That is actually true. That is the latest guidelines that have come out, and that's just based on the research we have at the present time. So we do know for 90 days we're good. That's when we think the antibodies might start to tail off, and that's why they're talking about that. However, now there's new data looking. Remember, antibodies are just one component of a vaccine that we're looking to create. That's the initial component, getting those antibodies up to fight off the pathogen. Then we have the T cell response that comes later. So that T cell response we're looking into now, and hopefully in future webinars we'll have an answer to see if that's still the case. But right now that is the case. And good reading.
And can you get your second vaccine earlier than the 3 to 4 weeks they recommend?
Oh, there's like a 4-day window. That's it. So for the one that's 21 days, maybe 4 days before or 4 days after, it does not have to be exactly 21 and 28, but there is about a 4-day window that they're approved for.
Okay, and then there's just a couple categories back to extraoral suction use that I'll just clarify. You do use extraoral suction device. You happen to use the Aegis system by the Child Group. There's somebody asking about the PAX 1000. There's several extraoral suction devices available. She asked it, or he or she asked if it's overkill. And I think your point is nothing is really overkill as long as you work with it. And then Jackie wanted to mention that the EPA has not allowed or approved fogging and electrostatic spraying. They're still looking for manufacturers for it, but I do know the hypochlorous is on the list N of the EPA, so it is a chemical that has been used for other disinfections. So just a couple of clarifications. Now we can get back.
Variants. Are the vaccines that are available now able to protect us against the new variants? If so, or if not, will we see booster vaccines in the future? We do have some promising information on some of the variants and the nature of the vaccine and the ability to prevent. So you do get some benefit, but it does appear that we will be seeing booster vaccines in our future. With the variants, again, it's a very similar question. We'll be getting an annual COVID vaccine. This is only my opinion, but based on till we get enough people vaccinated, that the pathogen will live. SARS-CoV-2 lives to replicate. And as it replicates, it tries to find ways to replicate better and more efficiently. So that's why you're hearing of I hate naming them the countries, but say the UK variant, which is very predominant right now. So it loves to replicate, so it lives just like we want to live. So right now, yes, we're probably going to be seeing an annual vaccine, but I don't see it any more often than that. If I had COVID-19, do you still recommend getting the vaccine? And if so, will it protect me against the other variants? If you've had COVID-19 in the past, like I've said before, please make sure you get vaccinated. But your vaccine is only going to be as good as the test studies show against the variants. And so there are different numbers. For instance, one of the manufacturers of a single dose had their order stopped by the South African government because it did not show a good enough effect on a certain variant. So we'll have to look and see how this works out. We have managed to get HIV, which figured out a way to get around so many different drugs for so many different times. We figured out a way to turn that into a chronic disease. Within a year, we've come up with vaccines that can prevent this disease. And you might not have 95% coverage against a variant, but you still have coverage. And that's really what's important right now. So it's important for all of us to encourage those that we love and those that are our staff and our patients to get vaccinated when it becomes available. My concern is right now there's a rush to vaccinate. What happens when that rush is over? How do we get the rest of our communities vaccinated? And we, as people that are trusted by our community, can truly help with that discussion. And we're back to other questions, Gary.
We're catching up on some of the vaccination ones. Would someone or could someone test positive for COVID via the nasal swab after the vaccination?
Not due to the vaccination, no. There is
Okay.
no live particles, so no.
Okay. But they could test positive even with the vaccination from COVID.
If they had COVID previously and they have some non-infectious particles, yes.
And this one a little related to something we discussed this morning. What are the malpractice considerations for dentists giving the COVID-19 vaccinations?
Well, the ADA is trying to protect the dental community from that. I think as long as we're under emergency authorization, like we are in Georgia, we are protected. But I do believe that the ADA, the American Dental Association, is working on eliminating the liability if we do perform vaccinations in our private office.
Great. And you may have answered it, but after resolution of a case of COVID, how soon can I get the vaccine?
My brain is getting tired, but if my memory is correct, it's around 30 days.
Okay.
But I'll be frankly honest, I'm not taking credit for that one.
And with the variants, some of the strains are more contagious, quote unquote. What does this mean? Should one not be concerned about fomite transmission in light of this?
No, I still don't think that we're worried about fomite transmission at this point. What it means is that it is more contagious, that it's twice as contagious as the regular virus is. And we've already seen how damaging that's been to our society, our economy, our practices, etc. So as far as I'm concerned, we wipe down every surface, whether fomites are there or not, whether I can see it or not. I'm going by evidence-based efforts that we have done over the years. And that's why we follow the guidelines that come up from the CDC on dental infection control, the recommendations from the ADA, AEHA, and OSAP.
Right. And even though Helene is older than you, her brain isn't tired. She came back with it's 90 days after you.
Thank you, Helene. My brain is exhausted. Helene Bednarz was the director of the HIV dental program, Ryan White Dental Program in Boston. She's vice president of HIV Dent, an organization we co-founded 24 years ago now, Helene. And she's my work sister, so thank you.
And then a question from her as well. Do you think tighter testing may be recommended in the future?
Good question, and that's a possibility. That's a good question. That's something that really needs to be researched, and I should have never said something nice about Helene. I knew that would come back and bite me, but a good question.
And then I just wanted to remind everybody that this, if you had to leave, this video is being recorded and catch it next week as well to final up. Go ahead and we'll try to finish off the questions.
There are more questions. Why are dentists getting vaccinated in some states but not others? Every state has the ability to make its own rules on who qualifies and who doesn't. They're usually in the first tier, but whether they're A, B, or C truly does depend on what state you live in. If a patient presented with a cough 2 months after they had COVID, should I ask for a COVID test prior to them coming in? There are very few cases of reinfection. There are some cases of reinfection, but if they've had a cough 2 months after they had COVID, most likely the cough is due to something else. Has there been any confirmed cases of COVID transmission from doctor or patient or vice versa? There have been cases that I'm aware of intra-staff transmission, normally front desk staff transmission, but I am unaware of any COVID transmission. What should I do if I receive a call from a patient after the appointment that they have COVID? Well, if you are following all the recommended infection control practices, if you're up to date on your standard operating procedures, if your staff is fit tested and wearing their N95s and you've done all of that, the only thing that you do, you could help them with some contact tracing if need be. But if you're following all of the recommended things in your waiting room, it's something to document in their record. That's about it. And I'm back to live questions. Gary, that was
Right.
quick.
I think we can get through and with just two. With the vaccination, one of the questions is if you got vaccinated and you do not get COVID-19, how can you infect another?
Could you repeat that question, Gary?
Yeah, if you do not get COVID-19,
You don't get it.
after both doses, how can you infect another?
That is a really good question because there's asymptomatic transmission. And so there is some concern about that. And remember, no vaccine is 100% effective. They're 95 and 94% effective. So even though you're fully vaccinated, you still can get infected.
Okay, and then this is way over me, but I know it's in your wheelhouse here. Current antibody tests are only for the N-marked ABS generated by COVID-19 infection. The question, any idea when commercially available tests for the S-marked ABS generated by vaccination will be available?
And I can honestly say I do not know the answer to that question, but we'll get back to you. Now I sound like a press person.
And then the final one, and we suggested a doctor reach out to their 3M rep. They've tried different N95s, different surfaces to fit, and can't find one that will fit this particular hygienist. Do you have any recommendations of resources they can go to find other sources?
I had the same issue with some of the 3N95s, and I don't know who sells the brand because it comes from our hospital, but O&M Halyard Incorporated, their N95 46727 regular and large actually fits our biggest heads. So it really does work. So I would recommend that. And again, these are NIOSH approved N95.
Can you read that again? I'll just type that in for Greg.
Sure. And I did remember Grady got Tyler Perry to do the question and answer on vaccination that really did help alleviate a lot of fears. So it's O&M Halyard, HALYARD Incorporated. It's N95 46727. The NIOSH is TC 84A-7521.
Great.
And I hope that helps.
We'll see if it does. Thanks so much. And the final question, it must come from somebody that knows you very well. Who is the greatest of all time? Who's the GOAT? And you can only choose one. Tom Brady, Diana Ross, or Anthony Fauci?
Oh, dang, that's a hard question. And so, as much as I love my Buccaneers, I'm going with Diana Ross.
Okay. Well, thank you very much. And thank you for the wonderful answering to all the questions and concerns. It was like air traffic control, trying to keep it all track of it. Certainly have generated a lot of information and provided even more. Obviously, and you can go to the next slide, if anyone has any questions or further questions for us or topics, or if you'd like to see us do this more often with the Q&A, please email us at webinars@henryschein.com. And please subscribe, as always, to our YouTube page, and you'll be notified when the next webinar is. Our next session is Friday, February 26, 2021 at 2 p.m. Eastern Time. Thank you, Dr. Reznik. Wonderful to spend some time with you, and thank you for all your knowledge and experience, and congrats on the Super Bowl champs.
Thank you, and thank you, Dr. Severance. Always an honor.
Thank you.